Thank you, everyone. Dr. Fabrizio sent his regards. He has some flu, so he will not be here. So we wish him a speedy recovery. I will present on his behalf first, and then I'll present my presentation. So all of us know that protocolizing care is important. So protocol-driven care may improve survival. Based on this study published in JACC of 204 contiguous consecutive cardiogenic shock related to acute MI, they found that there is an improvement in survival in 2018 compared to 2017, with a jump from 44% to 82% survival after protocolizing care based on early identification, minimizing inotropes, early impella support, and mandatory right heart catheterization. And they found that every 60 minutes delay in the mechanical support increases mortality by around 10%. And this diagrams also indicates that there is something called the golden hour that exists for cardiogenic shock related to acute MI, and the earlier you implement the mechanical support, the better the outcome. So the best practice in these situations is identifying patients early, try to identify the shock onset, and then find the shock onset to support less than 90 minutes. If you have a patient, you activate the cath lab, you stabilize the patient early, you revascularize based on guideline, and then you do systematic use of right heart catheterization to guide your therapy and wean your therapy. So if there is myocardial recovery, you try to wean the impella support if the patient is off inotropes and pressors and the cardiac power output more than 0.6, preferably more than 0.8. If there is no recovery, then you keep the device in and take the patient to the ICU or the CCU and bridge to something else. So patient comes to the cath lab, you need to make an access of almost always with ultrasound guidance, then assess hemodynamics. If you think the impella is needed, put the impella first, unload the ventricle, wean the catecholamines. If it is acute MI, do the coronary angiogram and do PCI if needed. If there is no MI, then reassess hemodynamics and see if there is a need for continuous hemodynamic support with impella or any other device. We have so many data about the benefit from unloading in pre-PCI, and it was found to be associated with improved outcome, improved survival to discharge, survival to 1 year, survival to explant, and survival to 30 days was also tested. So in a patient who is in the cath lab, has mechanical support, you did PCI, for example, then you have to reassess the patient before discharging them from the cath lab. So you need to check their cardiac power output, check the PAPI, pulmonary artery pulsatility index, and then based on that, you assess if the patient needs RV support or not, and if the patient is hypoxic. If the patient needs RV support, you will need to think about impella RV or ECMO, so ECPella, or, and if the patient does not need RV support, you continue just with left ventricular support device. If the patient is hypoxic, you will need to consider VA ECMO. The aim is to shift the patient from the red zone of 35% mortality when the patient has a cardiac output less than 0.6 and needing more than 2 inotropes to a cardiac power output more than 0.8 and needing no inotropes, so you aim for a survival of almost 90%. The shock trial found that the higher the cardiac output, the better the survival. So the cardiac power output is a surrogate indicator for survival. And the NCSI study showed that the higher the higher the number of the inotrope you use, regardless of your cardiac output, the worse the outcome. The Northern Eastern Shock Initiative Registry tried to make a registry and identify a score. It is not validated, but they came with a score called LANCE. They are still doing the validation for that. There are 5 points in that. Lactate at admission more than 4.8 takes 1 point. SCI classification less, SCI class C 1 point, SCI class D/E is 3 points, anterior MI is 1 point, and 3 vessel disease is 1 point. And they categorize it to low risk, medium risk, and high risk. Patient who get discharged, 100% of the patient with low risk will get discharged. About 50% of patients with high risk will get discharged, so that means 50% could not reach discharge, so they died. And interestingly, high risk patient will get higher chances of being mechanically ventilated compared to low risk, and the same with acute kidney injury. And I conclude Dr. Fabrizio's presentation. Next.
Any questions or comments from the audience?
We'll take it later.
No?
No questions.
No questions.
We can proceed.
You can proceed with the second one.
Yes. Next presentation, please. So next presentation was titled Higher Complexity Patient Needing Full Support and Escalation. I think the better title is The Power of Pimpella 5.5 and Escalation Therapy. So I do have these disclosures. So I present the case. We had a 58-year-old male smoker, hypertensive, in mid-May, presented to a local hospital with anterior MI, had a cardiac arrest with shockable rhythm, and had 15 minutes CPR. They achieved ROSC successfully. They did the primary PCI to the LAD and CIRC at the same time, inserted impella and inserted the balloon pump and ECMO, and his EF was 3%. He continued on 3 inotropes. This is his angiogram. The culprit was the proximal LAD was fixed, and the CIRC was fixed. The RCA is CTO, so was left alone. 2 days later, they could not wean ventilation. They could not wean the ECMO or the balloon pump or the inotropes. They took him back to the cath lab. They found that there is no other lesions except the mid-LAD, so they did IVUS-guided PCI, and they attempted the RCA CTO, which was complicated with perforation that was eventually concealed, and there was no tamponade. So 2 weeks after that, the ECMO and the balloon pump was removed. EF improved slightly to 15%. Patient was tracheostomized because they could not extubate or wean from ventilation. 3 weeks after admission, he developed subarachnoid bleed in the hospital, had no neurological sequelae. He lost about 30 kilograms and had no bed sores. 4 weeks after that, was transferred to another hospital for rehabilitation, pulmonary, physical, and neurological. During that stay, he had a stormy course. He had pulmonary edema, needed 2 inotropes to maintain MAP and urine output. Lactate was continued to be above 2. LVEF dropped. RV function was normal. Severe pulmonary hypertension, no significant valvular disease. So our team was consulted to see if there is anything else to do. So we assessed the patient, found him salvageable. His inotrope dependent, high lactate, multiple runs of non-sustained VT, severe pulmonary pressure with normal PAPI, severe pulmonary hypertension with normal PAPI, no evidence of infection, inadequate nutrition and support. So we transferred him to our hospital. He's Intermax 2. So it's important to mention this. This is an important score that if you have a patient with cardiogenic shock related to LV dysfunction, you need to know which category is that. So this patient has refractory shock, has Intermax 2, inotrope dependent, low weight, tracheostomized, previous large bore access, previous subarachnoid bleed, severe pulmonary hypertension, severe LV dysfunction, normal RV, no significant valvular disease, and no mechanical support at the moment. So what to do with this patient? If mechanical support, which one? how long you should leave the mechanical support. Is the mechanical support a destination? So we had a lot of discussion, and we said we'll take over the case and proceed. So based on this diagram, which was published in the AHA, there is escalation of therapy, and we found it's predominantly LV dysfunction. So we looked at the peripheral angiogram, and this is not suitable. So we looked at the right axillary and the left axillary, and we found it suitable. So we found the left axillary more suitable, and we looked at the LV gram. There is no LV thrombus, and echo showed that as well. So we put the Impella 5.5 in, and it was of a good support. We choose the Impella 5.5 because there is no pigtail, so it will not be arrhythmogenic, and it is less likely to cause hemolysis, and it will give a full support of the heart. 12 hours after implantation, patient is off inotropes, cardiac power output is 0.7, only levosimendan, significant drop in pulmonary pressure, good urine output, and is tolerating feeding. 24 hours after that, the pulmonary pressure is halved, no bleeding at the site, tolerating feeding well, physiotherapy started, fully anticoagulated, and repeat CT brain showed no evidence of bleeding. 40 hours after that, all inotropes stopped, started on afterload reducing agent, sedation are off, cooperative, awake, obeying commands, moving all four limbs, and was found good candidate for LVAD. Day 5, started mobilizing to the bedside, to the armchair. Again, there is no evidence of infection or bleeding, so we decided to take him for an LVAD on day 7 with a planned procedure. LVAD was successful with the closure of the axillary site and removal of Impella 5.5, taken back to the ICU on minimal inotropes. Day 8, off inotropes, started on low dose ramipril, extubated, tracheostomy with room air, sitting at the bedside. Day 11, mobilizing with assistance, continued on TPN to improve his nutrition status, and he's awaiting bed in the ward. Day 18, patient is discharged on warfarin and SAPT with guideline-directed medical therapy for heart failure with reduced ejection fraction. 1 month after that, patient actually was discharged and going to the gym using treadmill, and currently he's waiting for a heart transplant. I think the take-home messages here is never to give up, especially if the patient is salvageable. Full assessment is important and must before choosing your mechanical support type and deciding on it. Impella is undoubtedly a potent LV unloading device and can be used to recondition or precondition the patient to receive LVAD. Catecholamines are toxic to the heart, so reduce them and stop them as soon as possible with the concept of decatecholaminization. Teamwork and collaboration is a key for success. Thank you.